Okay, I want to welcome everybody to today's webinar, the training for Icd-10 Internal Medicine specialty. My name is Mellitus. I'm a certified coder with MTBC, and I will be presenting this webinar for you today. Okay. Any questions that you may have, you would put in the question box on the side of your screen. There is a question box. You can open it with the expanding of the plus or minus. And at the end of the WebEx, I will try to do the best I can with answering the questions. If not, we will ask you to email it to MTBC and somebody will get back to you with the answer. Okay, so MTBC was founded in 1999. We currently serve 60 unique specialties in 42 states. We have over 2,000 employees and we operate 24 hours a day, 7 days a week. We are ranged among the Technology Fast 500. We are also included in the 500, 5,000 company. We have 3 international offices. We are also a certified SureScripts solutions provider, and we're also listed on the NASDAQ. Okay, so what we're going to go over today on this WebEx webinar is some chronic conditions, including diabetes, heart failure, obesity, hypertension, any chronic ulcers, coronary artery disease, and BMI. Okay. Okay, so again, we have done the webinar to show you the difference between Icd-9 and Icd-10, but we will go over it again because I'm not sure, who has been on the previous webinars. So currently the Icd-9 has 3 to 5 characters. The only the only alphabetic character currently is the E codes or the V codes. There's the characters can be anywhere from 2 to 5, which are numeric. Always at least 3 characters, and then there's a decimal after the 3 characters. Icd-10 is going to have 3 to 5 characters, 3 characters before the decimal again, and up to 4 characters after the decimal. The first character is always going to be alpha. All letters in the alphabet have been used except for the letter U. The second character is numeric, and then characters 3 through 7 can be either alpha or numeric. Alpha characters are not case sensitive in Icd-10. So, chronic conditions, diabetes mellitus, chronic kidney disease, long-term insulin use, and or dialysis status are very important for diabetes. Documentation, respirator dependence for patient with COPD, artificial opening status, meaning a colostomy. Old MI is a very important chronic condition for internal medicine to be documented. Heart failure, organ transplant, and amputee status is very important. Obesity and morbid obesity. We cannot code obesity or morbid obesity just on the results of the BMI. The doctor has to document if the patient has obesity or morbid obesity. So the doctor needs to document that. Okay, so some chronic conditions that should be used for Icd-10, which should have been used for Icd-9, is long-term current use of insulin. The Icd-9 code is currently V58.67, and now you should be using the Icd-10 code effective October, which would be Z79.4. So these are the codes that are very important for an internal medicine provider to document at least once a year. I know for HEDIS and any kind of quality measures, they're looking for these codes. Tracheostomy status, this is just some examples. There is other statuses. Dialysis, renal dialysis status is very important if the patient has end-stage renal disease, but of course, we as coders, we cannot automatically assume the patient is on renal dialysis without it being documented in the chart note, saying that the patient is on hemodialysis. So it has to be documented, and then we can code it. It's a risk adjustment. These are all risk adjustment codes, which would make your RAF score go higher. Below the knee amputation, above the knee amputation are very important to be documented once a year. A lot of insurance companies, many insurance companies will wipe the slate clear beginning of the year, so you would have to document again so they know that the patient has the amputation. Kidney replaced by transplant, and then an old MI. So if you look at the Icd-10 codes for below knee amputation, they did specify more specific now, right leg versus left leg. Above the knee amputation, the same thing, right leg, left leg. The kidney transplant, you have two different types of codes. You have either if the kidney transplant status, just that the patient had the kidney transplant at one point, but you're no longer treating them. Whereas aftercare, if you're treating the patient for their for their kidney transplant, you would use the Z48.22 because you're treating the aftercare of after having the kidney transplant. That's pretty much right after. Otherwise, you would use the Z94.0 for status. And again, old MI is very important to be documented. Okay, so there's 5 diabetes mellitus categories in Icd-10. We have diabetes due to an underlying condition, drug or chemical induced diabetes, type 1 diabetes, type 2 diabetes, other specified diabetes mellitus. So originally, in order to indicate type, we used to use the 5th digit for type, and if it was controlled or uncontrolled. Now we actually have a whole code just for type 1, which would be the E10. That already includes that 5th digit, so we don't need to have that 5th digit to explain type 1 or type 2, where before we had to in Icd-9. So Icd-10 is much more specific, so they have their own codes. So the important part is to link if under any kind of condition is related to the diabetes, meaning it was a manifestation, it was a complication. So in order for us to code it, we need to know if there is a relationship. We can't assume in a relationship. It has to be documented with keywords. The manifestation keywords are diabetic, so diabetic kidney disease, diabetic ophthalmological manifestation due to diabetes. So the patient has glaucoma due to diabetes. That will then let us assume the relationship. Well, it's not really assuming, it's being able to know the relationship. And risk adjustment scoring is higher with the when it's a manifestation or complication. So you're getting more points towards your risk adjustment score. So it is important to link the manifestation or the complication, but you have to document it in the chart clearly enough for us as coders to show the relationship. We cannot assume it. So The other thing, the categories except E10 above, which is the type 1 diabetes mellitus, insulin use should be used as the second code, Z79.4. It is understood that E10 type 1 is already using insulin. That is how the guidelines are shown in the Icd-9 code book. Icd-10 code book, that it is already assumed, so you don't have to put insulin use for type 1, only type 2. So I think that was it. Okay, so we're going to go a little deeper into it. So Icd-10, the combination codes, what they're doing is type of diabetes, whether it was drug-induced, whether it's type 1, type 2, the body system affected, and the complications affecting the body system. That's Icd-10, that's the combination codes. In Icd-9, you would always have to need 2 codes when coding a patient with diabetes and a manifestation. But in Icd-10, many of the manifestation codes are included in one combination code. Not all, but many. So chronic kidney disease. So these are the exceptions. Chronic kidney disease, it will say the patient has a manifestation of renal manifestation, or it will say that it has the chronic kidney disease, but it doesn't know the stage. So the diabetes mellitus will say patient is diabetic with chronic kidney disease as one code, and then the chronic kidney stage needs to be the second code, which N81.1 is stage 1, N18.2 will be stage 2, N18.3 will be stage 3, and so forth. The N18.6 is end-stage renal disease. Where, if you notice, I'm really trying not to put the unspecified code. It's very important to be specific because Medicare, the purpose of Icd-10 is to be specific. And if you're not utilizing it properly, Medicare and other insurance companies can come back and start questioning your charts. You don't want that to happen. So unless you cannot confirm what stage it is, then you can use the unspecified, but within the next visit or two, I would definitely make sure that you find out what stage it is in, rather than just keep using the unspecified. I would not use unspecified because it's easier, because going forward, you're going to have to change it in October of this year to the unspecified, and then next year, because Medicare is giving an extra year to get it perfect and right, you're going to have to change it again. Do you want to change it again? It's a lot more work. If you know the stage, put the correct stage. If you know the site of the pressure ulcer, make sure you document that too, because as a coder, we cannot assume where it is. We need you to put that the pressure ulcer is on the heel. It also is going to ask a little more specific information regarding ulcers, which we'll get through later on in the webinar. If the patient had poisoning due to any kind of drug-induced or the drug-induced diabetes, then you would need to put what drug it was first that caused the diabetes, okay? So say T36 said that it was from, let's just say, I got to get a medication, Humira. Say that the Humira caused the diabetes, even though that's not a medication that I can't remember off the top of my head. But if it's what caused the diabetes, then you would use the T36, you would use the diabetic code second, and then any additional codes after the diabetes of what is the adverse effect to the patient. What did it do, okay? If diabetes is due to an underlying condition, so if they had pancreatitis, which caused the diabetes, you would also, again, first code what caused the diabetes, and then any diabetes codes afterwards. So if the patient had diabetes with a renal manifestation, or if had an ophthalmological, so you would do the, that, plus if it's type 2, you would do the Z code for the insulin use, if they're on insulin and it's type 2, and then again, if there was any other codes that need to go after that, you would also do that. But you have to first code the underlying condition. When a patient is on kidney dialysis, Z99.2, or if they've had a kidney transplant, you should also include Z94.0. These are also risk adjustment codes. Now, diabetes mellitus in a pregnant patient is not in the same section as all the other diabetes. The pregnant patient is always in their own section. Any kind of problems with a pregnant patient is always in their own section. So it would be in the O section. So just so you know, if a patient comes in with diabetes, don't use the same code you would use for somebody that's not pregnant, okay? It cannot be done. It's incorrect. Okay, so very important. This is how the documentation should be for a coder to properly code and also an auditor to come in and look at your note. It's not even just the coder. It's if somebody comes in to look at your note, if you have to send a copy of your note to another doctor because the patient is moving, they're moving and they need to go to another doctor in another state, everybody that looks at that note needs to be able to know the patient's history and conditions. So it's important that you document everything that is going to make it easy for anybody to look at that note to pull out the correct information on this patient. Very important. So the documentation you should have on your notes for ICD-10 would be the type. So type 1, diabetic patient, has developed moderate, non-proliferative, diabetic retinopathy with macular edema. If they don't have macular edema, you do without macular edema. ICD-10 code would be E10.331 for a patient that has type 1, diabetic, patient with developing moderate non-proliferative diabetic retinopathy with macular edema. Okay, so another example, documentation in an office note for insulin-dependent patient has diabetic neuropathy in the left hand. You see how detailed these documentations are? It's very important to have the detail. So, you want to make sure your EMR is ready. So insulin-dependent patient has diabetic neuropathy in left hand. When not documented as type 1 or juvenile, then the default will be type 2. So what's missing from this is we don't know if the patient had type 1 or type 2. So if the patient has type 1, make sure you document type 1. We can assume, just go with type 2. We are allowed to default, not assume, but default to type 2 for any insulin-dependent patient with diabetic nephropathy if it's not documented. But if the patient had type 1, we would be coding it wrong because we don't know that it was type 1. So it is recommended to put type 1 or type 2. That also, if they're insulin dependent, is important to put. If the patient has a manifestation, so diabetic nephropathy is saying that it's a relationship, it's a manifestation, it's a complication of the diabetes. And which area? The left hand. So rather than just putting in the hand, put left hand and where the diabetic nephropathy is. more specific, we need to know where the neuropathy is. So very important. So Icd-10 codes would be E11.41 because mono, you know, some things we will understand if it's in the hands and we know that it's mononeuropathy because it's only isolated to the hands. And then insulin use, because it does say insulin dependent, which is very important, but type 2 also, because we are using a type 2 code. E11 is type 2, E10 is type 1, then the patient is on insulin use. But it does say we need to know the patient's on insulin, and then we should be adding the insulin use when coding, which again is risk adjustment for internal medicine, so that's important. So it is extremely important to document correctly, okay, especially for diabetes, because there's so many complications that could happen, okay? And there is high risk adjustment scoring for it. Okay, so next thing we're going to go over is heart failure. So we need more specific. In the past, we used congestive heart failure, CHF. It was documented as CHF. So what did we use? We used 428.0. We need to be much more specific with Icd-10. We need to know you can use, if we only see CHF, well, of course we would have to use I50.9, but I am not happy with that because the insurance company can question why you're using too many unspecified codes. So I would not recommend continuing the way that we've coded or documented for many years, because every year they've gotten more specific and more specific. Now they've actually put it into a new coding system that shows how much specific for the accumulation of the last many years. And I understand a lot of people haven't gotten sufficient training on coding, so, but that's why you're in this webinar. It's very important to learn as much as you can, hear it often as much as you can, to remind you how important it is to document properly and be very more specific, much more specific. So, I mean, if you put systolic congestive heart failure, and we don't know if it's acute or chronic, we can use 150.20. If you do document acute systolic congestive heart failure, we can use 150.21. We cannot assume if it's acute or chronic. We would have to put unspecified. Again, the same thing. Going down, we have acute on chronic. We have unspecified diastolic, so it's systolic versus diastolic. And then unspecified diastolic, acute or chronic diastolic congestive heart failure. So this is how much detail we need. If you don't have the detail, then at least put systolic, also put, but also try to find out the information. Do follow-up on, okay, is it acute or chronic? How long has the patient had it? It's just a little more information you need to get to more specifically document, okay? So we just have to get more information. There's many ways you can do it to make it easier for your staff. Asking the medical assistant, maybe the medical assistant should be going through this training so that they can ask the patient the questions. There's many ways that you can make this work. It's not, it can be done. It's just figuring out the best way for your practice. Okay, so what's the difference? Let me just see some. Oh, okay, so it's actually continuing because diastolic, okay, so this is continued. So acute on chronic, diastolic, so again, systolic, diastolic. If they have both systolic and diastolic, there's also codes for that. There's either unspecified, because you won't know if it's acute or chronic. You don't know if it's acute on chronic. So there's three options and if you don't know the answer, it would be unspecified. So there's acute, there's chronic, there's acute on chronic. It has to be documented legibly for us to understand as a coder, you know, what this patient has. Again, if you're not sure if it's acute or chronic or acute on chronic, go with the unspecified, but I would not do too many of the unspecified codes. Okay, BMI, very important. You can bill, especially on an annual physical, you can include a diagnosis code for BMI, and some insurance companies want you to do it across the board, putting BMI on all the code, on all the billing, or in the documentation. You want to make sure the BMI values are documented. Very important. If the patient has 25 to 29, their BMI, they're considered overweight. You can document the patient is overweight, and that's another diagnosis code that you can use is currently it's 278.02. The obese, the patient, if they're 30, if their BMI is 30 to 39.9, you would put it in as obesity, I should say obesity. It's E66.9, and then 40 and above, a morbid obesity, or if you want to put severe obesity. It's important to put obesity, I just found out, versus obese. So you may want to fix that on your hard copy. The morbid obesity is E66.01, and it should be documented. We cannot assume as a coder that if the patient has a BMI level that's obese, that we can treat obesity, we can code it. We cannot do that unless the doctor documents it. It's something that if you do any kind of obesity training, it would you would put that you discuss to the patient any kind of nutrition and exercise counseling, indicate what you've given the patient to help them with their obesity, and then how much time you had spent on counseling the patient should be documented also. And, you know, there is some coding that you can code for counseling, but you'd have to look more into the medical policy on that. These are the Icd-10 codes on the bottom for the BMIs, okay? And honestly, they've actually been more specific, if you look at this, from 20 to 29, 21 to 21.0 to 21.9, whereas previously it was, if you're with, you know, under 19, anything under 19 would have one code, anything from 19 to 24 would have another code with Icd-9, anything from 25 to 29 would have another code for Icd-9, but now it's more specific of what their BMI is, and it's from it's, you know, within the whole point there. Okay, so that's going to be for Icd-10. Okay, very important is if the patient could either be borderline hypertension, they can also be, I'm trying to think, elevated blood pressure is different than actually diagnosing the patient as hypertension. So unless we see documentation saying hypertension, right now anything I-10 includes hypertension, period, whether it's benign, malignant, essential, and high blood pressure. It's all I-10. Okay, borderline hypertension would be an R code, R03.0, which I heard that the levels could be changing. So you should really look into that of, you know, the 120/80 guidelines may be changing. You would use any additional codes to identify tobacco dependence or tobacco use, okay? There is no presumed relationship between heart disease and hypertension, but if the provider documents that there is a relationship, then we can use the codes here. We have I-11.0 if they have hypertensive heart disease with heart failure. Again, document if it's hypertensive heart disease versus hypertension, one line, heart disease, another line. We cannot assume the relationship. You have to say that there is a relationship. And we need to know if it's with heart failure or without, okay? And if it's with, you have to put what type of heart failure. And of course, without, if they don't have it, there's nothing to code. But, you know, they do want the additional. So you have to put what type of heart failure. Systolic, diastolic, acute, chronic. Again, we need to have more specific information. So hypertensive heart disease with, you know, the documentation would say with congestive heart failure, acute systolic congestive heart failure. Then we would know the second code. So, okay, so this is a guideline that both is good for ICD-9 and ICD-10 and has not changed. They do assume, the ICD Corporation does assume a relationship when a patient has both chronic renal disease and hypertension. So, and what this, if you have hypertension documented on one line, and then you have chronic renal disease, okay, or chronic kidney disease, stage 5, stage 1, we need to know the stage, of course, always need to know the stage, and we can assume the relationship. So that, and that's also with ICD-9, and many doctors don't know that, but we do have to assume that there's a relationship and there's a totally different code. It's not, currently the code is being used as 401.9 with the chronic kidney disease, which could be 585 point whatever, 2, 3, 1, 2, 3, 4, 5, and which should be coded as 402, 403. There's a different coding system. When we get the claim, we would have to change it to that because there is an assumed relationship, okay? So I know the coding has been incorrect with the ICD-9. So ICD-10, very important. If you do, you should assume the relationship of hypertensive chronic kidney disease. If you don't, the coder will have to assume the relationship unless you document there is no relationship. But hypertensive chronic kidney disease, we would need to know which stage because each code is different. So if you see I-12.0, we can only use hypertensive chronic kidney disease if with that code only if the stage, it's stage 5 or end-stage renal disease. If it's stage 1 through 4, the chronic kidney disease, then we have to use I-12.9. But either way, we do have to know the stage of the chronic kidney disease because we need to use that as a second code. Because all this code is saying is the patient has hypertensive chronic kidney disease. It's not telling you the exact stage of the chronic kidney disease, and we need to know that. They need to know that, okay? And we need to know that. So it's important to put stage 1, stage 2. We cannot go into a lab test or any kind of testing. We need you to document it. We cannot pull it from a lab. It has to be in the note. Again, if the patient decides to go to another physician, it has to be in the note. They're not going to have the labs. They're going to have the note. The auditor that comes from the insurance company, or if you do an internal audit, they need to see it documented in the chart, in the note for that date of service for that patient. Okay, very important. Okay, so coronary artery disease, we have 414.01. Now, the ICD-10 code is more specific. That is very basic. Coronary artery disease of the native coronary artery. That's all it's telling you. This, we need to know, is there any angina? Okay, is it without angina, with unstable angina? So we have to know, is it stable or unstable? And documented spasm, with the documented spasm, any kind of other angina, and an unspecified angina. So if we don't know, if it just says CAD with angina, we have to use the unspecified. If it doesn't have angina, you should put no angina, okay, in the documentation, or without angina, so that we can use the I-25.10. Okay, so again, more detail. Icd-9, okay, so chronic ulcers. These are not the pressure ulcers, okay? This is what you need to know. We need to know what, where, of course, the site. Is it a chronic ulcer, and what site is it? And then what the breakdown of the chronic ulcer is, okay? Is it a breakdown to skin? Is it has it gone to the fat layer of exposure? Is necrotic of the muscle? Is necrotic of the bone? And if we don't know that, we have to use unspecified severity. So of course, we need to know the site. We need to know if it's the left or right foot, the severity, okay? We do need more specific, it's important, okay? And these are the codes. So it went from 1 code to 5 codes, right? Is that 5? Yes, 5, because it's more specific, okay? And I guess what the equal to the 707.15 would really be the L97.509. So they have added more specific, but we do need to know, we would like to know how more specific it is. So again, if you're EMR, you need to talk to the patient, to people with your EMR, to make sure that they may have put it in the template of, being more detail to do a pull down. I'm not really sure, what your options are, but definitely this is something you need to look into getting straightened out. Okay, so these are some of the resources that you can look at for Icd-10, Icd-10 and anything with MTBC, which I am going to go show you one thing here. So these are just some of the websites. I will bring them back. I just want to go through everything. We do have Medicare also. You should go onto Medicare and see what their requirements are. These are some more AHIMA, Icd-10 Watch. You can look up. These are some tools and resources for Icd-10. If you have any questions, you can always contact us at info@mtbc.com. I am going to go into this resource for Icd-10, and I'm going to give you a little more detail on that. If you have any questions, you can also contact somebody at the phone number that's on the screen currently. Okay. We will have the recorded, we should have the recorded live broadcast of this within 1 week of this webinar. I just want to go back a little bit. So this is the website that there's Icd-10 Solutions with MTBC. Okay, we do have some solutions, some options. If you go on this website, it will give you what options, a little more detail on the options. I'm just going to go over them quickly. You can ask about electronic charge capture. All you would need to do is put demographics in, and this is an option. You wouldn't have to use our EHR, but you can use the electronic charge capture. That's one of the options. The interface for electronic charge capture, which is here, interface with existing EHR, and then the coding services. We do have coding services, so if you do need coding services for your E&M codes, Icd-10 codes, you can also contact us for that as an option. And then we don't recommend Superbill Icd-10 because it would be so much and so many pages, because they have so much more complete, more detail. It's not really recommended because you could have a Superbill that's 1 page now that's 10 pages. Between the ink and the paper, it's not cost effective. Also, it's very confusing. There's way too many codes to go through. It'll be time consuming. We do not recommend it, but if you do need it, we can do it. So that's an option too, but again, we don't recommend it. There is the electronic charge capture. I understand. I'm not that completely familiar. I'm a little bit with it, but you know, it doesn't have to be part of your EHR. It's more so you just have to put demographics in, and then you know, electronic information will come up. So again, please just go on the website. If you're interested in anything, email, contact them, and they'll give you some information on it. But if you do need help, we are here for you, okay? And I just wanted to make sure you understand that. So this is the website right here, the mtbc.com resources ICD-10, okay? So write that down. And I'm going to try to go over some questions now. Do we wait until 2001, 2015 to use Icd-10? That's when it's required. You would have to check with your software because I'm not really sure. They are doing testing. Medicare, I know Medicare, some of the insurance companies have been testing the Icd-10. They may start accepting it earlier. You really do need to check with your carriers because, you know, they go on the website, say UnitedHealthCareOnline.com. They may say we'll start and accept them September 15th, September 30th. I'm not really sure. Each insurance will be different. But yes, October 1st, 2015, it is required that all providers start using their Icd-10. Very important. I only see, what's all the questions I see? Yeah, I'm not really seeing any other questions. So being I'm not seeing them doesn't mean that they're not there. I just cannot see them. If there's any questions that I have not addressed or have not seen, and you do have additional questions, please feel free to contact MTBC through email, and they will get back to you as soon as they can with an answer. I do hope you did learn a lot from this webinar, and again, good luck on your Icd-10. Thank you. Bye-bye.